AARDA is pleased to have this session dedicated to patients and patients as advocates, and we'll be focusing today on the patient's role in step therapy reform. Now, I'm Randy Ruda, the President and CEO of AARDA, the American Autoimmune Related Disease Association, and it's my pleasure to talk about step therapy reform, which is such a challenging issue for so many people with autoimmune disease and actually any chronic condition or serious illness where there are bureaucratic processes, there are practices that occur within health insurance, design, and different parts of the healthcare community that really interfere with how patients and their physicians are able to get the best care for those patients where they need it, when they need it, appropriate to their health and well-being. And I'm very pleased to be joined by two terrific experts in this space, Dr. Harry Garanter, pediatric rheumatologist and actually a board member for CSRO, a terrific leading organization, and he can talk a little bit more about that if he would like. And then Ben Chandok, who's Senior Director of State Legislative Affairs at the Arthritis Foundation, someone who I've seen do amazing work in helping organize patients at the state level to speak with their state legislators about step therapy reform. So with that, Dr. Garanter, maybe you could tell us a little bit about your experience with this challenge, this barrier, sometimes known as fail first, which so often I would think would frustrate a rheumatologist, you as a physician, in getting your patients the care that they need.
Thank you, Randy, and it's an honor to be here. It really is frustrating for everybody, I think, except for the folks who are creating the barriers to treatment, because they make money off of this. And I think part of the thing that we have this underlying myth that step therapy and prior authorization saves money. And personally, I haven't seen any data to go along with that, but it does cause significant stress. It interferes with treatment, and it interferes primarily with the patient-physician relationship, because at least my style with going through things with patients is we'll go through and say, here's what your diagnosis looks like, here's the options for what medicines you have. They all sound horrible. Which one upsets your stomach the least? And that's one we'll try to go with. And then I start looking to find out if it's on the formulary or not. The people who are creating these pathways believe that I think first about which drug am I going to make the most money on, and that's how I make a choice. And it's not that at all. That's not how doctors think. That's not how patients think. It's not good medicine. And so I think that this whole fail first concept sounds great in theory, but in reality, all it does is delay care, and it actually causes some complications. There's a wonderful article that's just been published by Zachary Wallace and his group in Boston, where they looked at medicines that they were infusing, which are primarily biologic medicines, and how many over a couple-year period did they have to get prior approvals for, and what happened with them. So over 70% of the medicines they prescribed required a prior authorization. 21% were denied. Of those denials, 79% were approved with an appeal. And then, the 79% of the rest of that leftover medicine amount got approved after a peer-to-peer. In 16% of the cases, they were required to fail another medicine before they could get the medicine that the physician and patient decided. So, part of the reasons they gave is, well, 82%, the insurance company said, well, these are off-label treatments. However, there was no approved FDA treatment for these situations. So we were basically going through an exercise for which, it was going to end up anyway. So the bottom line is 96% of all of these cases that were denied were ultimately approved. And it would take, up to 30 or more days. And along the way, patients received a lot more steroids. Over a 90-day period, the average was over 600 milligrams versus 160 milligrams for people who it was initially approved. So you're having complications as a result of all these delays because we've got to treat the patient. And so I think that is one of the criteria that just really infuriates all of us. that we've come up with treatments. We know for this particular patient there is a specific therapy that is going to be more effective than the cookbook protocols. And yet we have to go through these dances. Now, having said that, about 80% of step therapy protocols are things we're going to do anyway. So we're really only, we're only talking about 20% or so, maybe 25% of cases where we want an exception to a step therapy protocol. And we're arguing over that. And if we want low-hanging fruit to save money in the healthcare system and expedite therapies, here it is. And then you want to comment from the patient side as well.
Sure, and I'm glad that you highlight the 25%, 75%, or 20-80 distinction, because sometimes it's inferred that patient groups want to abolish step therapy in all cases, which isn't not necessarily true, because what we're really talking about is inappropriate protocols, inappropriate circumstances that a patient is made to try and fail a drug that for medical reasons is not appropriate for them, and that's the reason why you're filing an appeal. Like, let's be clear, like there's a medical reason why you think that patient should be on that. To your point earlier, it's not a financial one. You're not making more money off of it. It's a medical reason that you want this patient due to their medical history or their disease profile or the progression of the disease, the experience, that you want that patient on that medication. From a patient perspective, it's a total black box for most of it, like understanding that this is even happening, why the protocol is in place in the first place, how to navigate that appeals process, how to talk and speak about that on a language with the insurance company and able to have some empowerment over that appeals process, and that's a total frustrating. From the patient side of things, like we often hear complaints from the health side, but as well as the financial costs, like you're talking about saving the system money. Like one thing that we often hear from patients is not just the frustration with the process itself, but the consequences of having to try and fail, emphasizing fail, meaning that medication is not working, to prove to get to the next step, which may be 2, 3, 4, there may be 4 different drugs they have to take before they get to the medication that you thought was going to best fit their disease profile and their personal circumstance. In the meantime, emergency room, hospitalization, God forbid surgery, these are all extraordinarily expensive procedures and sites of care that the system was meant to prevent. Unfortunately, due to this inappropriate step therapy protocol, which may only be 20%, but the inappropriate protocol, that patient has now had progression of the disease, irreversible circumstances, certainly if it's surgery, and removal in some cases like an IBD, removal of a colon or something like that, circumstances that can't be reversed. And the patient is also paying for that as well. Right. So there's financial consequences as a result that were significantly more than if they just gotten the medication that you preferred in the first place.
Well, and I think it's not just what I prefer, it's what the patient and I've decided
of course,
is the best for their situation. And I'm perfectly happy to be accountable for my decisions. On the other hand, people who are coming up with these protocols apparently are not. And if there are consequences for that, I just said I'm going to pay for this. It's not that I made this medical decision, but you can't get this medicine unless I say you have to get it.
Yeah.
Dr. Gwenter, I've heard from physician practices that the hoops that physicians have to go through, the number of phone calls, the kind of paperwork that their team members have to pursue just to try to make progress in this space. Could you comment on that? Because I understand it's like literally 40 hours a week sometimes for some of these practices to really be advocates for their patients.
A lot of practices have 1 or 2 employees at least who do nothing but prior authorizations. And so, I've got, 4 chronologically adult children, so I'm a little sarcastic, but we're paying for insurance company employees in our practice because all they're doing is interacting with the insurance companies about something that we shouldn't be doing. A brief estimate, the receptionist and nurse and I figured out in my office was probably about 15% of our time was spent just on prior authorization appeals and all this other stuff. And there's lots of ways to make this easier. I mean, why do we still use faxes? To get all this stuff done. Why is it that every single company has to have their own form? in Virginia, we passed a law a number of years ago that we thought was going to help with this, that there's going to be a standard form. And all the insurance companies said, great, we'll have a standard form. And once you get done with that one, then you can fill out our particular form because it's, and so it just, compounded everything. The other thing is, if they deny things, you'll get things, you'll have, 48 hours to respond, and the denial comes at 6 p.m. on Friday after you've left the office. And, 48 hours later, ain't nobody there.
You didn't know you had a deadline and you missed it. That's right.
And, there's other situations, for example, I'm supposed to be on call and be available 24/7, 365. They're available 9 to 5, Monday to Friday. And, those kinds of things just delay and interfere with the care. And, that's the whole point of this, is how are we taking care of people and what barriers are being put up to delay the care or interfere with us providing efficient care. These are a lot of them. There's just too many intermediaries between, the physician and the patient and getting a treatment. If you try to, you got to decide, is it the insurance company that you talk to for appeal, or is it the pharmacy benefit manager, or is it the specialty pharmacy, or is it some other pharmacy, and by the way, they're all owned by the same people in many cases. But you've got multiple layers of administrative hoops to go through. For what? We know from data from all of us, we're talking 4 or 5% are ultimately going to be denied. If you push hard enough and long enough, you're going to get it. Why are we paying them to give us a hard time? It's the only service industry I know of that we pay to give us a hard time.
Well, and as Ben said, that delay, you could have negative reactions to the medicines that are approved that isn't best for that person. And the delay in and of itself, I've heard people say, I have a permanent disability. My condition is permanently different than what it might have been if I'd gotten on that therapy initially. I know AARDA sponsored research recently asking the general public, not just people with chronic conditions or autoimmune disease, but the general public as to who they feel should be making decisions about their health care. And over 90% of them said they wanted that to be the physician in consultation with the patient, not all these middlemen who are kind of weighing in potentially for different reasons than that patient's best well-being.
Sure, and I think again, we're talking about serious chronic illnesses that where delay is going to result in permanent problems. If you lose cartilage, it ain't coming back. You lose your colon, and it's not coming back. You lose neurons with multiple sclerosis, they're not coming back. And so appropriate treatment in the appropriate time and the appropriate intensity is important. Many of these protocols, and I understand the rationale, say, well, you need to start slow and work your way up on treatment. But in fact, for many autoimmune and other conditions, what you need to do is jump in hard and fast and shut everything down, and then you peel things away. It's the oncology, induction and maintenance model. Well, in fact, if you think about cancer is an autoimmune disease because our immune system didn't, detect those cells. And so the style of treatment should be the same. And instead of starting with, medicine that may not work, and then you have problems as a result, by the time you get to a medicine that's going to help out, there's already been damage. We learned that in pediatric rheumatology in the 70s and 80s and 90s. It's time to catch up. From an administrative perspective.
Absolutely. And I think there is effort to help policymakers understand the problem and then also get ahead of that problem through some reform. And I'm encouraged by that. I know legislation's been introduced at the federal level in Congress, both on the House and Senate side, the Safe Step Act that would start to put some of these reforms in place, basically guidelines around how utilization management and step therapy might work. But you've been active at the state level. Do you want to talk a little bit about what that conversation is like? And then Ben, I'll come to you because you've actually been a real leader in that space. But I think in Virginia you've been...
Well, it took us 4 years in Virginia of trying to get a step therapy exception process through. And basically it was a matter of a lot of education and a lot of discussion and refuting not lies, but not complete truths that were being put out there about how step therapy worked. And part of the education process was saying this is not to get rid of step therapy. This is for the minority of folks who require an exception. And how do we make that exceptional process for exceptional patients more transparent, more efficient, more effective, and allow the patients to get the medications that they require because of their individual situation faster and easier. Not have them have to repeat failing medicines once they've already taken them and it didn't work. To have a rapid response, to get an answer in 72 hours if it's a normal request, or 24 hours if it's an emergency. There was a lot of horse trading legislatively at the end, and part of it was, not unreasonable things. For instance, the pharmacy benefit managers wanted us to have a better definition of what does being stable on a medicine mean, or what does being, successful on a medicine. That was an appropriate, I think, point. Insurance industry wanted us to say that, yes, if you failed a medicine on your previous insurance, so you couldn't go back 5 years or 10 years or 3 insurances ago to say, well, I tried that and it didn't work, that if you were on a medicine in your previous insurance, then you can stay on it. Again, not what I liked, but it was not an unreasonable point of view. And so I think part of it is, yes, we can set out our absolutes. Legislation's always about compromise, but I think in the end, the patients and the citizens of Virginia came out better.
Great.
My concern and my issues now is, okay, let's see how you implement it. And how are you going to try to find the loopholes? Because what we find in many of these situations is whack-a-mole all the time. But Ben, what have you found in other states?
No, absolutely. And I would just say that, again, I want to emphasize that these bills do not abolish step therapy. And we're really talking about certain circumstances, again, that it's inappropriate applied. So we're reforming that process, like you said, the appeals and exceptions process. And primarily, what we saw as easy solutions from the patient side of things is if we're really hearing complaints about the protocols themselves and the appeals and exceptions process, then let's tackle those cases where we think that it's being applied inappropriately. And what does that mean? So the good news, we kind of talked in depth about the issues of what happens when step therapy goes wrong. The good news is there's something you can do about it, and these bills at the state level and now on the federal level as well is one way that you can do that. And utilization management, to go back to what you're talking about before, like step therapy and prior authorization, are pitched as savings to the system. So from a volunteer standpoint, from a patient side of things, what we try to do at the Arthritis Foundation is make that real to a legislator on the state level or the federal level. What does it mean that you're failing a drug and not working? What does it mean that a step therapy protocol is inappropriate or burdensome? These words that we use in the policy community, what does that actually mean? Well, it means, like you said, you tried and failed that before. That's an inappropriate use. If your insurance company is making you try and fail the same drug year after year after year, and you have to budget, this is a real life example, from an unfortunate patient of ours, from January to March, every single year that you're going to be out sick because you're going to have to try and fail that same drug before, that's an inappropriate use of a step therapy protocol. I think the legislator understands that, and it makes it easy to see why this reform is needed. Because there may be certain circumstances, if the protocol is designed appropriately from a clinical standpoint, that a patient should try a drug that is cheaper and works as well as all the others. Unfortunately, if the protocol is not designed that way, then that's not going to be the case. And so to go back to what the solution is, so what we see to reform the protocols themselves. So if the formulary itself is designed, the step therapy protocol is designed in a way that only reflects the cost of the medication to the insurance company and not clinical reasons, then you're going to have circumstances where the patient is trying drugs that aren't better for them by definition. So we want to make sure that the protocols are at least take into consideration clinical criteria, and that they do that in a transparent way. So the clinical criteria used is posted in an easily accessible manner, ideally on the web, like that's what these bills do, so that the patient and the provider can easily see what the insurance company took into consideration and the reason why that patient has had to try and fail that drug before. And not just for cost reasons to the insurance company. And I want to emphasize cost to the insurance company because that drug may not be cheaper to the patient actually in the lower formulary tier.
Sure.
And then we want to reform
it's both insurance and pharmacy benefit managers.
Yes,
We need to
absolutely.
include all of them.
Yes, absolutely. And then the appeals and exceptions process. So from a patient standpoint, this is just such a frustrating process. It takes an inordinate amount of time, weeks, months even. We've heard in the rheumatoid arthritis space, certainly. It's not transparent. They don't know what their rights are. They don't know the reasons for an exception. And since they don't know why they were made to try and fail the drug in the first place, they don't necessarily know what they need to submit to overcome that, whether it's failure, like what does failure mean, or like another reason why they might get past like a medical necessity reason. So the bills just reform that process. You said 72 hours, that's standard. So we try to make sure that in all non-emergency circumstances, in 72 hours, you get a grant or denial. So that way the provider or the patient in that case can file the necessary paperwork to try and get and overcome that delay in treatment, which you talked about earlier, and get on that medication that their prescriber preferred. And 24 hours in a case of emergency, because we think like in a case of an emergency or an exigent circumstance, there's no reason that it should take longer than 24 hours. And then back to what you need to submit and what your rights are. Insurers have all different standards about how to overcome and appeal that step therapy protocol and how to get an exception in place. So to make it easier for both patients and providers, we thought, let's standardize the exceptions process a bit, at least across the state regulated plans, which is what state legislators can address directly. So we want to make sure patients don't have to try and fail the same drug over and over again. That's an easy one. The patient is stable on a medication. They've been on that medication for 5 years. It's working for them. If they have to try a step therapy protocol, interrupt that treatment, I mean, it's pretty easy from both sides why that would have some devastating, again, health and financial consequences, both to the patient and to the system. And if the drug that the insurer prefers is not in the best interest of the patient for medical reasons, that's another reason it should not the patient should have to try and fail that drug. So those are the types of exceptions we try to get placed into law. And the federal bill is based on those state bills that we've now been successful in about 27 states, and we've got 10 more on our list this year, and work through at least covering all of the state regulated plans, and then Congress will hopefully act to cover the ERISA market.
So, the AARDA, the organization that I represent, launched 2 years ago, first in Michigan and then nationally as a national campaign, Let My Doctors Decide. And it really is to call attention, because many people don't even know that this dynamic is occurring. They may or may not even have this conversation with their own physician, or their physician may not, really keep them posted on all the steps that you're going through. So what we want to do is just create an understanding among stakeholders, and that would be patients and their families. It would be physicians and others that are in the healthcare community, as well as lawmakers and employers who are making decisions, on behalf of their employees and selecting insurance plans and things. And so Let My Doctors Decide was intended and is actively pursuing an education and awareness program in conjunction with many organizations, including both of yours, to really help create an environment of understanding and recognition that the current system is failing patients and physicians relative to what it's trying to achieve. And that is for that small percentage of people who have chronic conditions or serious illness or multiple chronic conditions, where they're being treated in a one-size-fits-all process by these algorithms and kind of artificial tests that are applied to them by the system, and yet that's not really helping them. So we're really looking to create a understanding that exists, call attention to it in a way that then can be a motivator for patients themselves, their families, and other stakeholders to learn more about this issue, maybe get on board some of the reform efforts that you are both involved in. So we're excited about that. Part of what we were able to bring forward is doing research with Emory University, again, first in Michigan, because that's where AARDA is based, and then nationally looking at health plans across the spectrum of public and private health plans, commercial plans, Medicare Advantage, the Medicare fee-for-service program, really understanding, what's happening there. And I was actually surprised to see how many of those companies got failing grades. C grades at best, and then failed. And
Those of us in the business,
you would not have been surprised.
We're not surprised.
Well, what we did is, it was one of the first times though where you were taking a set of metrics, and it was really how many barriers does your plan put in between you, your physician, and the care that you need. And so if it was like 5 or more, these folks got an F. It was like 3 to 5, they got a D, that kind of thing. And it was kind of shocking to see these grades applied through a scorecard to those plans. We hope that it will be a point of departure then to have a conversation that brings insurance companies and PBMs and employers and others who are really in a decision-making process forward to try to solve this problem together. How does that comport then with some of the work that you've been doing to help educate state legislators, help build on our awareness activities to then motivate change?
I think one of the biggest things is having people tell their stories and report them to central locations. One of the things that helped us with the step therapy bill in Virginia was through the Medical Society of Virginia and patient coalitions that we had. We asked people to say, if you're having problems, tell us your story. And when we went to insurance companies to say, well, this is what's happening, they go, oh, no, it's not.
Right.
And they'd open up the notebook and say, well, here's this example, and here's this example, and here's this example. The person with most data wins a lot of the time, but you also need the faces and the stories to go along with the data to convince people about that. So I think that really was one of the big things. Some of the other things that I've worked with patients on doing is, again, if you have an ERISA plan or if you're getting insurance through work, is you go to the HR person, or whoever the person is who bought the policy, because they're the real customer,
right.
not you, and certainly not me, and say, by the way, this may not have been what you were told by folks when they sold you this plan, but here's the reality of what happens. I think the other part is you appeal to the Bureau of Insurance. One of the best things that we've done in our office is when you have patients who are upset about this stuff, and one thing to understand is that at least 40% of people will not appeal. Either the doctor says it's a waste of my time, I'm not going to do it, you take care of it, or patients are just don't know to appeal. But our front office staff had patients, and we had a room in the back with a phone and the numbers for their state legislators, and a little bit of a script. And you could have them go back while they were pissed off at the time and say, would you like to speak to your state legislator about what's going on right now?
Sure.
And we started off doing that when Virginia went to Medicaid managed care and just sort of switched people to different things. But the concept works all the way through, and it's an easy thing to do. I think the other thing that people underestimate is docs don't think about this stuff very much, quite frankly. And really one of the things we're trying to push with the Arthritis Foundation in Virginia and elsewhere is recruit your doc or their office staff to help you get through this.
Right.
Because once they can see that it works, then they get hooked on the process and they're going to start doing it for more patients.
Well, and that will inform the system, because I have heard exactly what you've experienced, where so often as you reach out to insurance companies and others, they treat what it is you're bringing to them as an aberration. Oh, that's an exception. Oh, that only happened to that person. Who is that and what can we do? But then you start to have that kind of reporting, that kind of engagement that would show, no, there's a pattern here. It's a lot of people that are being affected in that way. And that would strengthen, I would hope, internally, but certainly externally, a call to action to then change that. Yeah. Exactly.
And the Arthritis Foundation has really come up with some really nice one-pagers about how to appeal things. And so part of it is having that sitting out on your desk. So when patients are upset, you can say, here's here's what you can do, here's what we're going to do, on your behalf. But it's your insurance, and I'm, sorry, but you've got to do some stuff too.
Absolutely.
I mean, after all, medicine's a group participation act in so many ways.
That's right.
And this is included.
Sure. Let me just ask, I'm going to ask you to kind of issue a call to action for patients on their own behalf, but then on behalf of really helping the system be better. I'm curious whether any of our audience members would have a question at this point or a comment with regard to this challenge.
It's really about educating the patient and being an advocate for themselves. And knowing what way to go if you're denied treatment or insurance is denied. You have to start educating them into that component, as well as a physician, educating the physician on what hoops to jump through as well. I've lived it for long years and having to make multiple calls, not just to insurance, pharmacy benefits, to the physician, everybody.
So what we're talking about here has been personal. You've experienced these barriers firsthand.
Very much so.
Yeah.
But I have a very great physician who also is educated in those things. And that's what's key, having the patient and the provider both educated and both being on the same page.
Right.
It's great fun to go see legislators with a family and sort of say, now, can you explain why you don't want to pass this legislation that would help this child? And it's great theater, among other things, but it also works. And I think one of the things that I found, and it's confusing me, is physicians think of advocacy as something outside of them, and not realizing that every day they're advocating for patients in all sorts of ways, individually. But when it comes to doing system advocacy, it's like,
Sure.
oh my goodness, I can't do that. In fact, talking to a legislator is just like talking to a new patient.
And that would be true for the patient and their family members as well. Well, you're a part of an organization, you're on the board of the Coalition for State Rheumatology Organizations.
Right.
And I've seen them be very engaged on this issue. And I think, do you want to just comment on that? Because as an organization,
it was established really to help practicing physicians about, with local issues. We work on a federal level, but, rubber hits the road in the state legislatures for a while. And so we've been involved in a number of other coalitions with AARDA and other patient groups and physician groups, really working on the step therapy and non-medical switching issues, as well as prior authorizations and all these other problems that really interfere with the patient-physician relationship.
Sure. And have you, do you think that could be a model for other specialty or other physicians groups? Have you seen them pick this up? I think I have a little bit. You've seen it as well?
Yeah, and I think part of things in, the coalition that y'all are putting together about autoimmune diseases fits for so many of these situations. We all think about our specific disease and, our little specialty, and we're siloed so much that way. Part of the way I think about how I treat, and this applies really to this situation as well, is a quote I heard from Quincy Jones many years ago, and he was talking about music. And he said that, the essence of any musical piece is the rhythm. And then you have the melody, and then you have, in jazz you have improvisations on it. So to me, chronic illness is a rhythm. We all have, there are generic issues that are involved, in terms of, your insurance, your job, your siblings, the spouse, the family, everybody else involved. That's generic. The melody is each specific disease, and then each patient's the improvisation on the melody. Some ways I play jazz all day in the office, but I think part of our issues here is that we need to think about this as the rhythm of illness, and the issues that are really significant in rheumatology, works for Crohn's and colitis, works for neurology, works all the way across, and we need to have ourselves be able to step back as we talk and work together in these coalitions to really get things going. Because politicians say, well, we don't do disease-specific bills, and so if we're going to take money, give you money, where are we going to take money from? What disease are you going to take it from? Right. And my answer is always, well, that's why you're being paid the big bucks, because this is not a money issue, this is a priority issue. And do you have priorities, for patients and your constituents or not?
Well,
I think there's a
you've been
question.
a real voice. Yes.
Just wondering if you might weigh in on the ethics of this, because a patient being denied something that could help them, or being damaged because they happen to go through this process, it would seem like there's an ethical issue here. How do you feel about that?
Yes. No, I mean, why are we doing this? We're doing this for the patients. It's not about me, it's about the patients. And, if my job is writing a prescription or calling a legislator, how is that different? You know, I mean, that, you know, yes, you're not always going to be successful. I'm not always successful in my treatments. I'm not always successful in my advocacy. But the point is you have to do it. That's just why we're here.
Well, thank you. And Ben, go ahead.
Say something about the coalitions and the education piece, just going back for a moment, is I just want to emphasize Dr. Gawanter's point about the coalitions and the different disease states, is that the protocols that we're talking about are not unique to rheumatoid arthritis or any type of arthritis or autoimmune even. It affects disease states across the board. And that is the reason why whatever patient advocacy organization you represent, you should go and advocate on these issues, is because it affects so many different communities. And for the legislator, that is very effective, because if you don't know someone with arthritis, you know someone with cancer, you know someone with Crohn's, you know someone with lupus, you know someone with these diseases, and it makes it real for them. Like, again, going back to what I was saying before about broad concepts like utilization management or what is an inappropriate step therapy protocol, if you can make it real, a tangible example to the legislator, it's easy for them to vote yes, because they understand why they're voting yes. It's not, state legislators in particular, many of them are part-time. They have other jobs, other expertise. They are not normally experts in health insurance. Some are, but a lot of them have other jobs in banking, even if they're on an insurance committee, non-health related day jobs. And so you have to make it real and easy to understand for them, because their time is split in so many different directions. In Virginia, some sessions are 30 days. They have 30 days to be an expert on any given issue. 45 days
45 or 60.
to be an expert on a complicated issue like step therapy. If you can make it real, it's very easy for them to understand why this legislation is needed and why they should vote yes. And they're doing it for their constituent, they're doing it for their family member with cancer, they're doing it for their friend with Crohn's disease or whatever. It's really important. Like, from an education standpoint, that's why it's important for all chronic disease organizations and otherwise to engage in this effort.
There are those organizations that they can connect with. One of the things we'll do as part of this discussion is have resources posted along with this conversation, and I hope we can draw on what the Arthritis Foundation has done, some of the coalitions that you mentioned, same with CSRO. I think there are models there are ways to do this that are meaningful. I know AARDA has some of those checklist conversations you can have with your physician to understand if those barriers are starting to affect, your treatment, your plan of care. We'll definitely put that information forward. Any last thoughts as a call to action to patients? I mean, I think you've been pretty compelling.
If you're experiencing an issue, I would encourage any patient to contact the Arthritis Foundation to help you navigate that process. If we don't have the answer, we can certainly refer you to another organization that maybe have a helpful resource. But if you have a story, we have a story banking tool. Those inform our priorities. We engage in states where we see there's a lot increasing prevalence of issues with step therapy, with prior authorization, without out-of-pocket costs, whatever the issue is. These inform our priorities. Like, we are developing these resources to help you. If you're having an issue, we definitely want to hear about it. So not just as an advocate as a lobbyist to a legislator, but also if you're just looking for resources, I hope that Arthritis Foundation, CSRO, and AARDA can provide that for you.
Yeah, and I think to remember, legislators are hired help. We're paying them, and people forget that.
And they want to help.
Right,
and they
do want to help, and their intention, but they're pulled in a lot of different directions. And I think the other thing that really we all need to remember is we all think about, well, we're going to get this law passed. Isn't that great? It's what happens after that. And we have to stay on it, and we have to make sure that the law is implemented as designed. And, most legislation is like many of my 8th grade essays was nice first draft. And you have to go back and revise it, and the unintended consequences have to be dealt with. But if people aren't staying on top of it and saying, well, gee, this wasn't supposed to happen according to law, and letting folks know that it's not happening, then we're back where we are now.
Well, that's a really good point, and I know for AARDA, and let my doctor decide, that's something we're focusing on. We want to see that intent then be translated into regulations and programming. It might be the insurance commissioner that needs to look at that. It might be the governor who you want to keep in the loop. It might be a state health agency that needs to be involved. And actually, it should be those stakeholder organizations, the insurance companies themselves that are writing insurance in that state, the PBMs and others should be all a part of that conversation. Well, thank you so much. This is really, I think, instructive to patients, to everybody that we look to serve and engage in this issue. And the good news is there is momentum for reform. With the federal legislation, that's great, but the action really has been in the states. And as you said, Dr. Gwanter, these state legislators, that is their job, but they're also neighbors. They're also family members. They're people that are seen in their local communities at the grocery store. They have town hall meetings. These are opportunities year-round. I think, Ben, you said these sessions are short, but there's no reason you can't be talking to these decision makers year-round. And also with your employer and with your insurer to just provide some feedback so that at least our concerns are their concerns and are top of mind. Well, thank you both very much for joining me today. I really appreciate it.
Well, it's been an honor. Thank you.